This videotape, which you are about to watch, is entitled 4th edition of the AMA Guides, The Legal Perspective. The purpose of this tape is to give legal and medical professionals a concise overview and instruction in the most important legal issues dealing with the AMA Guides to the evaluation of permanent impairment. Let's take an historical look at the origins of the guides. In the 1950s, the Board of Trustees created an ad hoc committee on evaluating impairment to establish a series of practical guides for the rating of physical impairments of the organ systems. In 1971, 13 separate chapters were combined into the first edition of the guides. In 1984, the second edition was released. In 1988, the third edition. In 1990, the third edition revised. And in 1993, the fourth edition, the one we are discussing today, was released. What is the fourth edition and what is it not? The fourth edition provides a framework with clinically sound and reproducible criteria and methods of analysis through which physicians can evaluate, report on, and communicate information on permanent impairments. It does utilize up-to-date information on impairment and illness provided by knowledgeable clinicians and scholars. This book does not pretend to have all of the answers, nor does it have precise impairment percentages which should be blindly adopted by physicians, attorneys, and judges. When the fourth edition is utilized properly and within the proper parameters, it is a useful tool for physicians, attorneys, and adjudicators. The AMA Guides were created to bring greater objectivity to the estimation of permanent impairment. Ideally, through proper use of the guides, multiple independent physicians evaluating the impairment of the same patient will produce the same or similar impairment percentages through the guides. This is why the AMA Guides are currently being utilized in 40 out of 53 states and territories and may be adopted by additional states. In addition, the guides have started to be utilized in foreign countries as well, for example, Canada and Australia. With new states and territories adopting the use of the AMA Guides, there has been legislative confusion about how to word the AMA Guides enabling statutes. Is it permissible to utilize an old edition of the guides, as some states provide? For example, the third edition revised when rating impairment. The fourth edition is very specific about this point. The answer is clearly no. In those states in which the workers' compensation law requires that an old edition be utilized, physicians, attorneys, and legislators should join together to amend the Act to provide that the most current edition of the guides be utilized. It is important to remember that the guides were never intended to usurp the independent judgment of the physician in arriving at his or her opinion as to a diagnosis of permanent impairment. Persons utilizing the guides must remember that they do not provide a magic formula which turns medical information from and about the patient into a precise percentage by which the employee's industrial use of the body is impaired. Each state or federal agency that utilizes the fourth edition must translate on its own impairment information from the guides into disability ratings. And most importantly, impairment percentages from the guides should not be used to make direct financial awards or direct estimates of disabilities. This direct statement by the guides must be looked at by legislators, physicians, and attorneys in those states that have erroneously adopted this direct conversion method. For example, The state of Texas adopted a new Workers' Compensation Act in 1989. The act provided that supplemental benefits, which except for lifetime benefits are the only long-term benefits under the act, are only available to workers whose impairment ratings are 15% or more under the AMA guides. The appeals court in the Garcia case, in a decision dated 8/11/93, found that this was totally improper use of the guides. The court held that the improper use of the guides violated the equal protection provision of the Texas Constitution, and that this use of the 15% impairment rating threshold as a qualification for supplemental benefits is arbitrary and based on an impermissible and arbitrary use of the guides. The court found that the Texas Workers' Compensation Act, because of the improper use of the guides, was unconstitutional. Now that we have a basic understanding of where the guides came from and what their intended use is and is not, I will review key points from the legal perspective. When should the guides be utilized? A basic but crucial point to remember is that the AMA guides are only applicable to the evaluation of permanent impairment. First, what is an impairment? The guides provide two definitions. The first is a general definition found in the Impairment Evaluations section. This definition reads, "Impairment is an alteration of an individual's health status. Impairment, according to the guides, is assessed by medical means and is a medical issue. An impairment is a deviation from normal in a body part or organ system and its functioning." The second definition for use in assessments is found in the glossary. The second definition is impairment. Impairment is the loss of use, or derangement of any body part, system, or function. Now, what is a permanent impairment? Remember that a permanent impairment is considered to be unlikely to change substantially by more than 3% in the next year with or without medical treatment. If an impairment is not permanent, it is inappropriate to characterize it as such and evaluate it according to guides criteria. The fourth edition provides a crucial distinction between disability and impairment. Permanent impairment occurs when the degree of capacity becomes static or well stabilized and is not likely to increase despite continuing use of medical or rehabilitative measures. In liability issues, it is important to remember that disability may be caused by medical impairment or by non-medical factors. What counsel needs to know about the fourth edition? I have three basic rules for proof and defense of impairment under the guides. 1. Know precisely what must be proven under the guides. Don't prove less and do not try to prove more. 2. Lay a detailed foundation with the testimony of the claimant. And 3. Adequately prepare your physician to testify. What must be proven? If, for example, you are dealing with a respiratory impairment, the medical report, to be in compliance with the guides, must contain certain elements. The report also must contain the results of the symptoms associated with respiratory dysfunction. Thus, if the medical report is not thorough and does not cover all of these aspects, it will not be in compliance with the guides, and any award based on the report would be subject to challenge. Early chapters discuss the needed medical material and provide a report form to use. Foundation. Counsel should lay a detailed foundation through the testimony of the claimant, focusing on the impairment, its permanency, and its effect on activities of daily living. Preparing your physician. Frequently, physicians testifying as to permanent impairment are not properly prepared by counsel. Physicians should insist on being adequately prepared by counsel. Proper preparation by counsel should consist of 1. Going over the AMA guides generally. 2. Going over pertinent sections of the guides. 3. Reviewing with the physicians if the use of the guides is mandatory or discretionary. For example, can he or she deviate from the guides, and if so, to what extent? And 4. Reviewing whether the physician can utilize his or her discretion in arriving at an impairment evaluation, and if so, what factors can be considered. Proper preparation of the physician should include providing the physician with crucial documents. For example, a written summary of the testimony of the claimant, hypothetical questions to be asked, a copy of the applicable AMA guide section, a summary of the AMA guide's law or regulations on the mandatory nature of the guides, the rules on discretion afforded physicians under the latest edition, the key rules on pain, and typical cross-examination questions that the physician can anticipate. Key points to remember about the 4th edition. The 4th edition of the guides has some important new features, numerous new case reports and examples, the new Chapter 15 on pain, the adverse effects of pharmaceuticals, and the new glossary contains key information. The guides provide a wealth of information for counsel to utilize not just in permanent impairment ratings, but in all aspects of workers' compensation litigation. For example, the 4th edition deals specifically with apportionment, which is defined as an estimate of the degree to which each of various occupational or non-occupational factors may have caused or contributed to a particular impairment. 2 criteria must be met. The alleged factor could have caused or contributed to the impairment, which is a medical determination, and the factor did cause or contribute to the impairment. Another example is disfigurement. Disfigurement is dealt with as well in the glossary and is defined as an altered or abnormal color, shape, or structure of a visible body part. Many key workers' compensation concepts are defined in the glossary of the guides. For example, aggravation on page 316 is defined aggravation. This means that a physical, chemical, or biologic factor which may or may not be work-related contributed to the worsening of a pre-existing medical condition or infirmity in such a way that the degree of permanent impairment increased by more than 3%. On page 317 of the 4th edition, recurrence is defined. Recurrence. A recurrence requires no identifiable incident as a trigger to the medical condition in question. Rather, the patient has a resumption of symptoms or signs that can be related to the previously existing medical condition or injury. On page 318 of the guides, the 4th edition, employability is defined. This is the capacity of an individual to meet the demands of a job and the conditions of employment associated with the job as defined by an employer with or without accommodations. The 4th edition of the guides on page 317 defines what a new injury is. New injury. With a new injury, an identifiable new incident must be shown to have caused the injury. If it is thought that a preceding factor or situation, such as one related to an illness or occupation, might have had a role in the injury's development, then the causation must be established as described above. Physicians should be familiar with the definitions and explanations, as counsel can be expected to utilize these concepts when litigating issues on liability as well as disability. Discretion. Under the fourth edition, the training, experience, and skills of physicians have been emphasized, and they have been given greater discretion in arriving at impairment ratings. For example, the fourth edition states adjustments for effects of treatment or lack of treatment. In certain instances, the treatment of an illness may result in apparently total remission of the patient's signs and symptoms. Examples include the treatment of hypothyroidism and the treatment of type 1 diabetes mellitus. In those instances, the physician may choose to increase the impairment estimate by a small percentage, i.e. 1 to 3%. In pain evaluations, the fourth edition relies on the skill and judgment of the physician. The fourth edition of the guides, in certain circumstances, permits physicians to express an opinion as to the ultimate issue in many workers' compensation cases, i.e. disability. The fourth edition provides on page 2 that, in general, it is a physician's responsibility to evaluate a patient's health status and determine the presence or absence of an impairment. If the physician is well acquainted with the patient's activities and needs, he or she may also express an opinion about the presence or absence of a disability or handicap. Some physicians in occupational medicine, for example, have acquired enough experience and knowledge about workers and workplaces that they can provide useful insights on workers' disabilities and handicaps. The fourth edition of the guides contains significant changes for physicians, attorneys, and adjudicators. When utilized properly, the guides achieve their goal of consistency and objectivity in evaluating permanent impairments. We will now move on to a sample direct and cross-examination of the testifying physician in a model case. The case we will use is that of James Sample III, a truck driver who injured his back while unloading a truck and subsequently underwent a lumbar laminectomy. The independent medical evaluation of Dr. Brigham, referred to in these sample examinations, has been provided for you.
Prior to being involved in litigation, physicians and attorneys should attempt to first understand the philosophy, the concepts, the structure, and the use of the guides as a whole, as opposed to understanding and trying to use only isolated sections. Second, physicians need to perform a thorough evaluation without bias that is in compliance with the guides and able to withstand judicial scrutiny. Third, physicians and attorneys need to come to the depositions or hearings prepared, having thoroughly reviewed the reports, charts, and the pertinent portions of the guides. Fourth, all parties should come to the deposition with a copy of the latest edition of the guides. And finally, physicians need to answer the questions directly, tell the truth, and not be affected by the histrionics of counsel. When these guidelines are followed, the old practice of obtaining and using two polarized evaluators and averaging the results will no longer be necessary. At key points during the examination, explanatory comments will be provided on the screen.
Doctor, if you raise your hand before we begin, I'll swear you in. Do you solemnly swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
Yes, I do.
Doctor, do you waive signing and reading?
Yes.
Doctor, please state your name.
My name is Christopher Roy Brigham, MD.
What is your professional address, Doctor?
Occupational Health Resources, Forsyth Place, U.S. Route 1, Falmouth, Maine.
Would you please describe your education and training from college until the present?
I received my Bachelor of Arts degree in Biological Sciences from Rutgers University, Master's of Medical Science from Rutgers Medical School, and my medical degree from the Washington University School of Medicine in St. Louis. I completed a 3-year residency in family practice at the Eastern Maine Medical Center and subsequently was involved in a series of postgraduate training programs in occupational medicine, focusing on the evaluation and the management of work-related injuries.
Are you board certified?
Yes, I am.
In what areas are you so certified?
occupational medicine, and family practice.
Doctor, could you tell us what board certification entails?
Achieving strict standards established by the boards, including required prerequisites of study and practice and completion of written board examinations.
Doctor, at some point in time, did you have an opportunity to examine Mr. James Sample III?
Yes, I did.
When was that, Doctor?
August 28, 1993,
And where was that examination done?
at my office in Falmouth, Maine.
At whose request was the examination performed?
United Mutual.
Did you obtain the background of the claimant, Mr. Sample?
Yes.
What was that background, Doctor?
Well, referring to my report here, James III is a 42-year-old right-handed man. He's married and lives in Old Town with his wife and 17-year-old child. During the day, he reported that he would rest, watch TV, read, do light chores, and visit friends or family, and denied doing any heavy chores, cleaning house, or working. Prior to the injury, his recreation consisted of fishing, hunting, and bowling, but he reports only fishing a little now. He smokes 1 pack of cigarettes per day and reports 3 or 4 alcoholic drinks a week. He also consumes 6 caffeinated beverages per day. He's not involved in any community activities.
Dr. Brigham, did you obtain a prior medical history from Mr. Sample?
Yes, I did.
And what was that history, Doctor?
His past medical history was unremarkable. Having had a hernia repair and being allergic to penicillin, he denied any prior problems with his back. He did have a prior work-related injury to his left shoulder and was out of work for 2 months. This was treated conservatively with complete resolution. He denied any symptoms or dysfunction immediately to this injury.
Now, Dr. Brigham, did you have an opportunity to review the medical records of Mr. Sample?
Yes, I did.
And what did those records reveal?
Let's see here. On October 1st, 1991, he reports that while unloading a tractor trailer, he lifted a heavy box, twisted and got pain in his back. Later that day, the pain went down his right leg. A day later, he was seen in the emergency room and was diagnosed as having a back strain. He then sought chiropractic care for approximately 6 weeks without improvement, and then was seen by an orthopedic consultation. He had an MRI performed that revealed a herniated disc at L4, L5 with compression to the right, and following consultation with a neurosurgeon, on December 24, 1991, he underwent a lumbar discectomy at L4, L5 with findings of a herniated nucleus pulposus compressing the right L5 nerve root. Since his surgery, his treatment has been primarily passive physical therapy with analgesics. He's performed exercises in the past but discontinued them because of pain.
Now, what was Mr. Sample's functional status?
Well, as outlined in my report, he had significant pain complaints involving his right low back with radiation down to his knee. He reported that he could sit for half an hour, stand for an hour, walk for half an hour, and lift up to 10 pounds occasionally. He reported being unable to lift heavy weights and had some major difficulties lifting a heavy bag of groceries, bending, lifting, a variety of heights, climbing stairs and driving. He also indicated to me minor problems lifting a light bag of groceries, reaching above shoulder level, pulling, pushing, sweeping or vacuuming, and moving his neck. His most difficult task was driving his car over bumpy roads.
Now, Dr. Brigham, did you have an opportunity to review the occupational history of Mr. Sample?
Yes, I did.
Now, of what significance, if any, was that history?
Let me see here. He advised me that he began working at Jones Trucking in August of 1989 as a long-haul truck driver. This involved long-haul driving and assisting with loading and unloading. He would typically sit for 3 hours at a time, stand for a couple hours at a time, and lift frequently material up to 100 pounds. He reported he enjoyed his job, but had some difficulties with his supervisor and the employer. He had worked at another trucking firm in the past and does have a high school education. He's not worked since the injury and is receiving workers' comp and disability loan payments. He didn't have any long-term occupational plans. Dr. Cutter imposed work restrictions of 4 hours per day, no frequent bending, and no lifting over 10 pounds. A functional capacity evaluation had not been performed.
Now, Dr. Brigham, did you review the diagnostic studies?
Yes, I did.
What did they reveal?
See, the lumbar spine films of October 10th, 1991 and December 1st, 1992 were normal. An MRI scan, lumbar, performed on December 3rd, 1992 was reported to show an L4-L5 disc herniation centrally and to the left, but resulting in some encroachment on the right L5 nerve root. That was also noted, and some minor disc bulging at L3, L4, and L5-S1 levels. I had the opportunity to review the radiologist's report. However, the MRI scan was not available for my review.
Did you review his pain status?
Yes, I did.
And Dr. Brigham, what did this review reveal?
Well, the pain drawing here was abnormal. It had a score of 8, suggesting poor psychometrics. The pain disability index was quite elevated at 58 out of 70, 83%. That's consistent with a high level of perceived disability. The McGill pain questionnaire revealed primarily affective descriptors suggesting an exaggerated pain. His overall pain intensity was reported at a 4, horrible, on a scale of 0 to 5. The multidimensional pain inventory was consistent with a dysfunctional individual. The Center for Epidemiologic Studies depressed mood scale was elevated at 34. That's consistent with a depressed mood. And the Oswestry function test was at the 54th percentile. That indicates a perception of severe disability.
Did you conduct a physical examination of the patient?
Yes, of course.
Now, what did this exam consist of, Dr. Brigham?
The examination consisted of a detailed physical assessment focusing on behavioral and structural examination and a thorough low back exam, including observation, palpation, range of motion measurements with an inclinometer, and a detailed neurologic examination identifying negative, positive, and non-physiologic findings.
Now, what were the results of the exam?
Well, once again, referring to the report, the general observations had revealed him to appear healthy, although he was overweight and had a protuberant abdomen. He had no increased pulse rate when referencing pain, although he was somewhat irritable. He was cooperative and attentive. His affect was normal. He appeared comfortable during the interview, sitting continuously for at least 45 minutes. During the examination, he demonstrated significant pain behavior, including bracing and guarding and grimacing. His structural exam revealed lumbar hyperlordosis. His gait was normal. He had surgical scars. He was tender over the low back generally, but he had no focal paraspinal, vertebral, sciatic, sacroiliac, or coccygeal tenderness. He did have active trigger points in the right gluteus medius. His inclinometer measurements revealed decreased range of motion, particularly in flexion and extension. However, these were not reproducible, and these were inconsistent with the straight leg raising. Neurologically, his reflexes were intact. He did have some mild weakness of the great toe extension on the right, no evidence of any muscle atrophy. Sensation was decreased on the right, consistent with an L5 dermatome. His straight leg raising was negative sitting to 80 degrees, but when supine, was positive for back pain at 40 degrees on the left and 30 degrees on the right. There were numerous non-physiologic findings. He had light pressure on the skull, caused complaints of increased back pain. Rotation of the trunk as a unit resulted in complaints of increased pain. Superficial touch resulted in severe pain. Superficial pressure resulted in radicular pain complaints. Range of motion measurements were inconsistent. Range of motion inconsistent with straight leg raising. And a straight leg raising supine measurements were inconsistent with straight leg raising sitting.
Now, Dr. Brigham, did you reach a diagnosis?
Yes, I did.
What was that diagnosis?
Well, the diagnoses included chronic pain syndrome with symptom identification, depressive disorder, lumbar disc degeneration with radiculopathy, in a right L5 distribution and being status post lumbar discectomy. He had a myofascial pain syndrome, obesity, deconditioning, tobacco abuse, history of a shoulder and upper arm injury, and a drug allergy.
Did you reach any conclusions as a result of your examination?
Yes.
Now, what were they, doctor?
Well, Mr. Sample does have underlying physical pathology. However, his more significant barrier to returning to work is his chronic pain behavior, at least from my perspective.
Did you form an opinion as to whether Mr. Sample's condition has become static or well stabilized and is not likely to remit despite further medical treatment?
Yes.
What is that opinion, Dr. Brigham?
His condition has become static and well stabilized and not likely to improve.
Now, did you form an opinion as to the causal relationship between his injury at work on October 1st, 1991 and his current medical problems?
Yes.
And what was that opinion, Doctor?
Well, based upon the available information, to a reasonable degree of medical certainty, there's a probable causal relationship between the current complaints and the October 1st, 1991 injury at work.
Dr. Brigham, did you have an opportunity to evaluate Mr. Sample for permanent impairment?
Yes, I did.
What, if anything, did you utilize as a reference to achieve this rating of permanent impairment?
I used the guides to the evaluation of permanent impairment published by the American Medical Association.
Dr. Brigham, which edition of the AMA guides did you use?
I used the 4th edition.
Now, is the 4th edition of the guides the most recent edition?
Yes, it was just released late summer of this year.
Dr. Brigham, could you explain generally what the guides are and how they are used to rate permanent impairment?
The guides are a manual used to instruct doctors how to uniformly rate permanent impairment. The guides provide a standard framework and method of analysis through which physicians can evaluate and report on permanent impairment.
Dr. Brigham, are you familiar with the use of the guides to rate permanent impairment?
Oh, yes.
How did you become so familiar with the guides?
I've used them many times, probably over 1,000 times to rate permanent impairment ratings in patients.
Would you please explain the whole person concept of the guides?
Certainly. Every impairment under the guides must ultimately be expressed as an impairment of the whole person. When using the guides, the physician first must rate an impairment of a section or sections of the body and then convert this figure using tables provided in the guides to an impairment of the whole person.
Doctor, what were the results of your permanent impairment rating on Mr. Sample?
Well, the permanent impairment rating was performed in accordance with the AMA guides, the evaluation of permanent impairment, 4th edition. The presence of an objective evidence of radiculopathy, that being the sensory deficit in the anatomic distribution of the L5 nerve root, qualified for a DRE lumbosacral category 3, which is a 10% total body impairment. No additional impairment was given for neurologic deficit, loss of range of motion, or chronic pain, and neither the surgical treatment nor the results of the treatment affected the rating.
Doctor, would you explain how you performed your rating, specifically reviewing the tables utilized, how you used them, and how you arrived at your final results?
Well, I chose to use the injury or the diagnosis-related estimates model as outlined in the AMA guides. The guides advise us that we should assess the spine using the injury model if the patient's condition is one of those listed in Table 70, spinal impairments for cervical, thoracic, thoracolumbar, and lumbosacral regions. In this case, the patient clearly fulfilled the criteria for radiculopathy, and therefore the injury model was utilized. He met the diagnosis-related estimate category 3 for radiculopathy. In this category, the patient has significant signs of radiculopathy and receives a 10% whole person impairment. This is outlined in tables 70 and 72 and on page 102 of the guides.
Doctor, can you explain why you gave no additional impairment for the range of motion deficits, neurologic deficits, and pain?
Yes, it's inappropriate to mix the injury model with the range of motion model. The guides cautions persons evaluating impairments according to the guides that either one or the other approach should be used in making the final impairment estimate. And further, that if one component were used according to the guides recommendations, while the final impairment estimate was used with the other components, this would usually not be permanent, or that it mean pertinent or germane. And with a range of motion model of impairment, you would consider the specific diagnoses as outlined in Table 64. The range of motion impairment, if these measurements were valid, and a neurologic system impairment. The range of motion model may be applied when there is disagreement about the category of the injury model. However, in this case, it's really quite clear that he falls into category 3.
Okay, doctor, just a few more questions. What is Mr. Sample's impairment of the lumbosacral spine? That is, what is his impairment of the back?
Well, the guides state that in the injury model, the lumbosacral spine is considered to represent 75% of total body function. Therefore, the whole person spinal impairment, in this case the 10%, would be divided by 75%, yielding a 13% lumbosacral spine impairment.
Doctor, do you have an opinion based upon a reasonable degree of medical certainty as to whether this impairment is likely to be permanent?
Yes?
What is that opinion, Dr. Brigham?
Well, Mr. Sample's impairment is permanent.
That was an example of a brief but effective direct examination of an evaluating physician. The key to the success of the examination was the preparation of the physician, an understanding of the case, and the appropriate understanding of the guides. Effective cross-examination of the physician can be achieved by utilizing the information contained in Chapters 1 and 2, the glossary, and the chapters on the pertinent systems being evaluated. It is the responsibility of the attorney to make sure the physician is properly prepared. Proper preparation of the testifying physician involves 5 steps. First, go over the guides with the physician generally. Second, go over the pertinent sections of the guides. Third, review with the physician whether the use of the guides is mandatory or discretionary in the pertinent case. 4, review the extent to which the physician can utilize his or her discretion in arriving at the impairment evaluation, and what can be considered in determining impairment. And 5th, review what factors the physician may consider in determining permanent impairment. There are 5 main lines of questioning available to a cross-examiner of an evaluating physician. These are: 1, inadequacy of medical historical data; 2, inadequate testing; 3, lack of raw data available; 4, mistakes in use and application of the guides; and 5, lack of familiarity with the guides in general. The cross-examiner may explore all of these lines of questioning. The attorney presenting the medical evidence on direct examination should prepare his or her physician to deal effectively with these anticipated lines of questioning. We will now use the James Sample III case as an example of how these lines of questioning are actually utilized. Please note that due to time constraints, many lines of questioning are not followed up with as much detail as they would be in practice. Doctor, in formulating your evaluation of impairment, did you use the AMA guides to evaluating permanent impairment?
Yes, as you know, Mr. Babitsky, the state workers' compensation statute requires use of the AMA guides, and therefore I did use them.
And which edition of the AMA guide did you use, Doctor?
As I stated on direct, I used the most recent 4th edition of the AMA guides as required by the state's workers' compensation statute.
Now, Doctor, you testified in direct examination that you've utilized the guides 1,000 times or more to rate impairments. Is that correct?
Yes.
Were you ever trained in the use of the guides in medical school, Doctor?
No, it was not part of the formal curriculum.
Have you ever received any formal training dealing with the application and use of the guides?
Really can't say that I have.
Do you consider yourself an expert in the use of the guides, Doctor?
Yes, I guess I do.
Doctor, there were some major changes in the 4th edition. Is that correct?
Yes.
The new materials include case reports, new information on pain, and on the effects of medication. Is that correct?
Yes.
Isn't it fair to say that there were numerous changes in the philosophy ratings and definitions in the guides?
Yes.
Are you prepared today to go through these changes in the 4th edition, Doctor?
No. We don't have enough time scheduled for this deposition for me to review all the changes with you.
You would admit, Doctor, that as the guides are so new and you've been offered no instruction and training in the 4th edition, that you're not intimately familiar with all its changes. Is that correct, Doctor?
Partially. I'm not yet familiar with all the changes in all the chapters. However, I am familiar with the changes in chapters 1, 2, 3, and 15, which are pertinent to the permanent impairment rating in this case.
Do you know, Doctor, if changes that you are not aware of affect your report and impairment rating in this case?
Your question's unclear. However, I'll attempt to respond. If hypothetically there were changes that affected this rating and I was not familiar with those changes, they would possibly affect this rating. I'm familiar with the changes pertaining to the evaluation of permanent impairment for spinal conditions, including associated issues, and therefore I'm confident that my rating is correct and in accordance with the 4th edition.
In fairness, doctor, you would have no way to know the impact of changes you are not familiar with. Isn't that correct?
Yes, although I do not feel this is pertinent in this case.
Doctor, let's get down to specifics. What, if anything, is different in the combined value chart in the 4th edition as compared to the 3rd edition revised?
The combined values chart is the same. It's based on the same formula.
Could you explain the formula that the chart is based on page 322, doctor?
The formula is A plus the quantity of B times 1 minus A, where A and B are expressed as decimal equivalents. Basically, what we're saying is that the combined impairment is equal to one impairment value plus the quantity of the extent of the impairment of the remaining portion of the person which is unimpaired.
What about apportionment, doctor? How has the concept changed from the 3rd edition revised to the new 4th edition?
Well, the 4th edition clarifies the role of the physician in apportionment issues. The 3rd edition had stated apportionment being a determination of the degree to which each of various occupational or non-occupational factors have contributed to a particular impairment. For each alleged factor, 2 criteria were specified to be met: that the alleged factor could have caused the impairment, which is a medical decision, and in the particular case that the factor did cause the impairment, which is a non-medical determination. The 4th edition clarifies this by stating that apportionment, this being an estimate of the degree to which various occupation or non-occupational factors may have caused or contributed to a particular impairment. For each alleged factor, 2 criteria must be met. First, the alleged factor could have caused or contributed to the impairment, which is a medical determination. And then second, in this case in question, the factor did cause or contribute to the impairment, which usually is a non-medical determination. The physician's analysis and explanation of causation is significant.
Well, could you explain the could have caused and did cause rule in more detail, doctor?
This references issues of causation, stating that to decide that a factor allegedly has contributed to the occurrence or worsening of the medical condition, it is necessary to verify both that the alleged factors could have caused or contributed to the worsening of the impairment, which is a medical determination, and that the alleged factor did cause or contribute to worsening of impairment, which is a non-medical determination.
Would you explain the new rules with regard to interpolating, measuring, and rounding off, doctor?
The second chapter of the guides states that an impairment value that falls between those appearing in tables and figures may be adjusted or interpolated to be proportional to the interval of the table or figures involved. It also states that unless a generally accepted standard exists, for example in laboratory tests, that 2 measures made by the same examiner involving a patient or a patient's functions may be expected to lie within 10% of each other. It also states that the measurements should be consistent between 2 trained observers and that repeated measurements may increase credibility. It further states that with the final estimated whole person impairment based upon the valuation of one system or several organ systems, the results may be rounded to the nearer of the 2 nearest values ending in 0 or 5.
What are the 4 terms dealing with the frequency of symptoms or signs that are used in the guides, doctor?
Intermittent, occasional, frequent, and constant.
Could you define and explain these terms?
Well, yes. Intermittent means that the symptoms or signs have been medically documented to occur less than 1/4 the time when the patient is awake. Occasional means that the symptoms or signs have been documented medically to occur between 1/4 and 1/2 of the time when the patient's awake. Frequent means that they occur between 1/2 and 3/4 of the time, and constant means that they occur between 3/4 and all the time.
What terms do the guides use to describe the intensity of an individual's symptoms or signs, doctor?
Minimal, slight, moderate, and marked.
And would you please define these terms for us?
Yes. Minimal refers to symptoms or signs that are annoying but have been medically documented to cause appreciable diminution in the individual's capacity to carry out daily activities. Slight means that the symptoms or signs are tolerated by the individual and have been medically documented to cause some diminution of the individual's capacity to carry out activities of daily living. Moderate means that they have been medically documented to cause serious diminution of an individual's capacity to carry out activities of daily living. Marked means that the symptoms or signs preclude carrying out activities of daily living.
Doctor, would you explain the differences between the concepts of aggravation, recurrence, new injury, and causation under the fourth edition?
Well, as I previously explained, aggravation means that a physical, chemical, or biological factor which may or may not be work-related contributed to the worsening of the pre-existing medical condition or infirmity in such a way that the degree of permanent impairment increased by more than 3%. Reoccurrence requires no identifiable incident as a trigger to the medical condition in question. Rather, the patient has a resumption of symptoms or signs that can be related to a previously existing medical condition or injury. With a new injury, an identifiable new incident must be shown to have caused the injury. It is thought that a precluding factor or situation, such as one related to an illness or occupation, might have had a role in the injury's development. Then the causation must be established. Causation means that a physical, chemical, or biologic factor contributed to the occurrence of a medical condition.
Doctor, you would agree that the figures that you arrived at in your permanent impairment rating are not precise. Isn't that correct?
It depends upon what you define as precise. My assessment was thorough, my measurements are valid and reliable, and I followed the guides in the classification of the injury model to determine the correct impairment rating.
These are informed estimates, are they not, Doctor?
Yes, they represent our best assessment resulting from the consensus of an expert panel.
And the impairment percentages represent estimates rather than precise determinations. Isn't that correct?
Yes.
What is the margin of error for these estimates, Doctor?
I don't know precisely. However, the guides state that the final estimated value may be rounded off to the nearest value ending in 0.05, and this would imply to me that there's a margin of error.
Well, to accurately determine permanent impairment, we would need to know the margin of error, wouldn't we, Doctor?
Well, it would be helpful if we could specify like 2% or 3% or 4%, but this is not feasible.
And why isn't it, Doctor?
Well, as we've discussed previously, impairment ratings are largely estimates.
Would you explain how you can be so precise using rounding off and interpolating when the impairments are estimates to start with?
First, I would object to your characterization of precise. My measurements are thorough. The results are valid and reliable using the AMA guides. However, since rounding off can occur, I'm not certain it's fair to use the term precise.
Are you saying that your evaluation was not precise, Doctor?
My evaluation itself was precise and thorough, but in terms of the actual numbers of being precise in the guides, they're the estimates of expert panels in our best opinion concerning what those values should be.
Well, Doctor, you only saw this patient on one occasion, isn't that correct?
Yes.
And you rendered an opinion as to disability, did you not?
Yes.
Would you say that during that one visit you became well acquainted with all of the patient's activities and needs?
To a degree which I felt confident of rendering an opinion that he would be considered an individual with a disability and providing a clinical estimate of his functional capability.
Well, you are aware, Doctor, that the guides state that if the physician is well acquainted with the patient's needs and activities, he or she may also express an opinion about the presence or absence of a disability or handicap. Based upon this one visit for an IME exam, you felt you were well acquainted with the patient's needs and activities and thus were qualified to rate his disability?
Yes, based upon the thoroughness of my evaluation and my knowledge and skill as a board-certified occupational medicine physician with particular expertise in this area, I did.
Would you agree, Doctor, that if you were not really well acquainted with his needs and activities, that according to the fourth edition, you should not render an opinion as to disability? Isn't that correct, Doctor?
Hypothetically, yes.
Do you contend that you followed all applicable diagnostic and evaluating criteria as set forth in the fourth edition of the AMA guides to the evaluation of permanent impairment in arriving at the impairment rating for this claimant, Doctor?
Yes.
Was there anyone in the examining room besides you and the claimant?
No.
Did you have the claimant disrobe?
Yes.
Did you touch the claimant?
Certainly. How else can you possibly examine a patient?
Did you consider the claimant's age, education, work history, subjective complaints, and pain in arriving at your impairment rating, doctor?
Mr. Babitsky, as I have stated before, and is evident in my report, I performed a very thorough medical evaluation and followed the AMA guides accurately to determine the extent of permanent impairment.
So the answer is no?
I followed the guides and did a thorough assessment.
Well, specifically, how did you consider and utilize these factors, doctor?
Mr. Babitsky, I have previously answered this question fully. Once again, and hopefully for the final time, I followed the steps specified in the AMA guides, considered all factors pertinent, and Mr. Sample is classified as a DRE Category 3, rendering a 10% impairment of the whole person.
Doctor, isn't it fair to say that pain can result in a deviation from normal in a body part or organ system and its functioning?
Yes, it can. Pain is a multifaceted concept that transcends the traditional medical model of disease based upon pathogenesis at the tissue or organ level.
And isn't that the definition of impairment under the guides?
Well, yes, that is part of the definition of the impairment.
Thus, pain can result in a deviation from normality of use of a body part, and that's impairment. Isn't that correct, doctor?
Yes, that's possible, Mr. Babitsky.
In the present case, the claimant is left with intense pain in his back and left leg that radiates into the left buttock and is made worse by use of lifting, exercise, bending, crouching, sneezing, sitting, standing, and walking. Isn't that true, doctor?
Yes.
And you have stated that he is not likely to get better. Isn't that correct?
Yes, I consider him at maximum medical improvement, that is permanent static.
This means that he's likely to have this pain for the rest of his life. Correct, doctor?
Yes, to a variable extent.
And you did not rate the pain specifically because the 4th edition of the guide says not to do it. Correct, doctor?
Yes.
Would it be fair to say that the guide's explanation about why you can't rate pain is less than clear?
It's clear to me, Mr. Babitsky.
As I understand it, doctor, the guides state that pain is subjective and its presence cannot be validated or measured objectively. Is that correct?
Yes.
You did not award even 1% for pain because, in general, the impairment percents given in the tables and figures applicable to permanent impairments of the various organ systems include allowances for the pain that may occur within these impairments. Isn't that true, doctor?
Yes.
Doctor, as a person who was not good at math or science and thus became a lawyer, can you explain how, if pain is subjective and cannot be objectively measured, the impairment percentages in the organ systems could include the correct allowances for pain?
Not well. The fact is that pain is a difficult concept to objectify. It ranges widely and is considered in the classification, as in this case, with the Nonis model.
Is there a scientific relationship between the degree of pain and impairment?
No.
Are you aware, doctor, that the guides provide pain as a subjective perception? Usually no exact relationship exists among the degree of pain, extent of pathologic change, and the extent of impairment?
Yes.
Would you describe the difference between acute and chronic pain as defined in the 4th edition, doctor?
Acute pain is nociceptive. It's primary, it's short-lived, and the psychological consequences are minimal. Chronic pain, on the other hand, represents a malevolent and destructive force, is self-sustaining, self-reinforcing, and self-regenerating. It's not a symptom of an underlying acute somatic injury, but a destructive illness in its own right. It's often persistent, it's long-lived, and progressive with markedly enhanced pain perception.
Doctor, did you perform the requisite testing to arrive at an impairment rating for the claimant's pain?
I did not perform an impairment rating for the pain per se. I performed impairment rating based upon the specifics of the case and his injury, the classification for a spinal disorder.
You are aware, doctor, are you not, that the guides provide psychological testing is an integral part of evaluating pain. Using the Minnesota Multiphasic Personality Inventory has become standard. Other instruments include the Cornell Medical Index, Health Questionnaire, McGill Pain Questionnaire, Beck and Zung Depression Indices, and West Haver-Yale Multidimensional Pain Inventory.
Yes.
Did you perform these requisite tests to rate his pain, doctor?
First, I did include established pain inventories to assess his pain. However, as I've stated repeatedly, it was not appropriate to rate for pain other than that included in the injury classification.
Doctor, do you know how much pain this patient actually has?
No, only what he reports.
Is there any person who knows how much pain he has, doctor?
Yes.
And who is that person, doctor?
The examinee, Mr. Sample.
Now, doctor, you stated in your report several times that the patient was cooperative, did you not?
Yes.
Yet when it came time to do your conclusions, you found a significant behavioral overlay, did you not?
Yes.
Did this impact your rating, doctor?
No.
Are you a trained psychiatrist, doctor?
No, I'm not.
Did you follow Chapter 14 of the 4th edition in arriving at your opinion of exaggerated pain and somatic amplification, doctor?
He had findings consistent with that, but in terms of the rating of pain, or the rating overall of his permanent impairment rating, that Chapter 14 was not appropriate.
Was the claimant depressed, doctor?
The claimant did have a discouraged, depressed mood, as evidenced by some of his responses to the history, and also his elevated score on the CESD inventory.
And are you qualified to say whether his depression or functional overlay is the result of his industrial injury?
I'm not trained as a psychiatrist or psychologist. He did have that associated with that problem. He may or may not have had pre-existing problems relating to depression. So I really defer that area to somebody who's independent and trained, certified in psychiatry or psychology.
You are aware, doctor, that Mr. Sample reports that he feels discouraged and depressed, has disturbed sleep and insomnia due to pain?
Yes, I do.
And despite this fact, you found him negative for psychiatric emotional problems. Is that correct, doctor?
That was in reference to the review systems portion of my report. He had denied any previous problems of significant emotional or psychiatric distress, but as I've mentioned earlier, that there was evidence that there was depression, both in terms of his own history and his elevation on the depressed mood scale.
Are you willing to defer to a psychologist or psychiatrist on this point, doctor?
To one who is appropriately trained and independent, yes.
Now, doctor, did you rate all of the impairments?
Yes.
And according to your report, Mr. Sample has constant pain, numbness on the outside of his right leg to the knee, weakness of his back and right leg, disturbed sleep, and depression. Is that correct?
Yes.
And doctor, would you agree that if we believe this patient and his doctor, he is significantly impaired? Is that correct?
Yes, he is impaired, as indicated in my report.
Now, you stated that he was cooperative and a fair to good historian. Did you not, doctor?
Yes, as stated in my report.
And you believed him and reported verbatim his responses as to his injury, his pre-existing status, his health care providers, his occupational history, his lifestyle, his contributory factors, his other medical history, and pain. Did you not?
I did report the responses verbatim and did find him cooperative. I did not have a reason to disbelieve him, although on the basis of numerous non-physiologic findings, certainly a question could be raised about the reliability of some of the self-reports.
The only thing that you do not believe him about is his pain. Isn't that correct, doctor?
No, that is incorrect. I do not question that he has pain.
Do you have any way of measuring his pain, doctor?
Only in part. We have various rating instruments to characterize the perceived level of pain and the characteristics of that pain.
Does anyone else other than the patient know how much pain he is in?
No, at least not in terms of another person.
If we were to believe his testimony about his pain, he would be significantly impaired. Is that not correct, doctor?
Yes, he does have significant impairment, and this is included in his impairment rating.
Thank you, doctor. I have nothing further. Dr. Brigham was able to effectively withstand cross-examination because he was well prepared and knowledgeable. He knew what the law required regarding the 4th edition of the guides. He was thoroughly familiar with both the guides in general and the specific procedures used for evaluating the patient's back injury.